The Future of Healthcare Professionals, From Education to Practice by Allison Aronsky. Education for the future hospital team, that of physicians, nurses, case managers, and dietitians primarily, are frequently disparate. Physicians, registered nurses, case managers, and registered dietitians do not attend school together. They do not attend any kind of classes together. And this can be beneficial and harmful to the patient and to the team itself. Physicians tend to be disease-oriented and treatment-oriented in both their education and their practice. They see a higher volume of patients, and with an average of 20 seen per day, according to the Physicians Foundation 2018 survey. And their range of care is essentially assessment, diagnosis, intervention, establishment of interventions, evaluations. And again, they are diagnosis and disease-based. The interventions are fewer than those of nursing and can be considered, prescriptions, PT, rehab. Physicians also have lengthier paperwork required of them daily. As far as nurses go, they have a lengthier time spent with patients. They have a greater availability for follow-up questions and education based on that lengthier time. They see an average of 1 to 8 patients a day, depending on what unit they are assigned to. Their range of care is broad and includes ADL assistance, feeding assistance, ambulation, turning, and the 5 Ps: potty, pain, positioning, possessions, and peace of environment. Case managers. Case manager range of care includes assessment of triggers, assessment of needs, assessment of the support system. They work with the patient to establish coping mechanisms. They evaluate the treatment, and there's a high level of discharge planning. They see about 10 to 15 patients on average per day. The registered dietitian range of care includes nutrition assessment, nutrition care plan, and consideration of food, beverage, supplements, allergies, and medication interactions, as well as preferences and aversions with food. They also pay attention to the socioeconomic factors that case managers do. There's a high level of collaboration in the dietitian world. They work with the patient, the family, the provider, the nurse, and the case manager, and they see about 8 to 10 patients a day. Siloization is the separating of personnel or data into isolated units, usually resulting in reduced communication. And this is what is seen in hospitals in terms of doctors, nurses, case managers, and registered dietitians. Everybody kind of stays in their lane and focuses on their aspect of patient care. There are some advantages to this. For the patient, the physician and the nurse's immersion in their own field allows for a greater understanding of their field, a deeper knowledge in their field. And then the disparate units with deep dive leave little room for gaps. If I'm caring for everything nursing, there's not going to be any gap there. I'm not going to be paying any attention to the physician side, in terms of my actually implementing it, because I'm going to be, deep diving into my nursing care. As far as advantages of siloization for the team, according to Dhruv Kular, the MD, he said, you learn in a safe and hierarchical environment. So this continued team focus reveals how much there is to learn and provides helpful previews to the further medical education. And then also chain of command structure is enforced and maintained. And that definitely leads to patient safety, chain of command. Disadvantages of siloization. For the patient, there's disjointed treatment plans. Treatment plans need to cover everything, and if everybody's working separately, that can really be disjointed and can leave gaps. Treatment plans have to include all facets: social, physical, emotional, all of that. So, the health continuum is understood and maintained. Physicians ultimately lead the team, but if you do not have a team mentality, if everybody's not working together, if there is siloization, other members may not feel as responsible as the physician, and that can lead to medical errors and poor patient care. As far as the team goes, a disadvantage of siloization is that team members may not understand each other's roles. They may not know what a case manager is supposed to do or a dietitian can do. And then that can lead to delegation challenges and errors. So what is the fix? The National Center for Interprofessional Practice and Education has worked to give 6 universities grants to support interprofessional patient safety, nursing, and MD school activities. So the nurses and the MDs work together in these schools to do the following. They do grand rounds. They go to the hospital to learn how to round together. And then they do clinical simulation rounding together with a debrief to go over, okay, what was missed, what did we do right, what did we do wrong. They have conferences and web-based learning modules. They do treatment plans together as a group. They notify patients of family deaths and, bad news reporting they do together. And they have multiple debriefing sessions to see, okay, what did we miss? Where did we go wrong? Of course, led by nursing instructors and other instructors. So what's another issue in terms of current medical care? And that is the maldistribution of providers. We're finding that a lot of providers are rushing to urban areas rather than rural areas. And why is that? Well, rural areas are less financially solvent. The hospitals there are much smaller. They don't get as many grants, so there's less of a financial incentive. Smaller population and reduced diversity means the medical care can be repetitious. There's little need for specialization that many providers desire. I mean, there's a need for specialization, but they just don't have the means to support it, so you can't do it there. According to a 2019 NPR article, Arthur County, Nebraska population has been declining so much so that over the last 80 years, they have not had a permanent full-time physician. There was a highway mobile health clinic that stopped once a week until the 90s, but that became so cost prohibitive that now Arthur County has no full-time medical care. People have to drive long distances to get to that. Urban areas see higher pay, cutting-edge medical education and participation, more innovation, and family practice focus. So what is the benefit of being one of the only local doctors? A 2018 article published by the American Association for Physician Leadership interviewed Michelle Kenny, MD, who stated that it kind of pushes you to use more of the broader knowledge you've learned because there aren't as many specialists available. So she feels that there's an opportunity to lead, there's an opportunity to expand rural services, and the continuous utilization of your core knowledge just really cements that. Some of the solutions to, this reduced capacity for doctors in rural areas is rural mentoring. You have a rural doctor working with a younger doctor, showing them, the innovations that they do and the interesting things about the area and the population. Bonus pay, of course, both immediate and length of service or patient satisfaction based. Social matchmaking, show new doctors interesting parts about the town that may be personal to them, hiking, whatever, swimming. And then if universities would do a little bit more rural recruiting. So how can we also work to understand preventative care, which is something that would call physicians to both urban and rural settings? A 2012 article by Wolfenden on using telemarketing approach to assist in weight care reports that too few people enroll in weight loss maintenance programs, only 3 to 6% of the population. And providers rarely address diet or activity guidance. In fact, only less than 35% of patients reported that their doctor gave them any guidance on weight or diet when clearly they had either a weight or diet or activity issue that they should have received guidance on. In this Wolfenden article, they're saying the best practice interventions are face-to-face or e-counseling combined with individual print education materials that is healthcare professional activated. So in other words, don't wait for the patient to come to you, you come to the patient. How can public health nurses help with this preventative care? According to a 2013 Alberta study, public health nurses are preventative care experts. In Alberta, the preventative care benefits reach both patients, systems, and society. It's not just, they go out into the community and do mother-baby visits 48 hours after discharge and at 2, 4, 6, 12, and 18 months. They check growth, provide vaccination information, breastfeeding support. These nurses mobilize, the village for better outcomes by establishing a food bank for local high schoolers and diaper drives to help indigent parents. Working for the social justice and social determinants of health. The Canadian Nurses Association National Expert Commission released a paper in 2012 that included recommendations for care that says poverty and education levels are the two greatest threats to preventative care. And in order to uncover healthy living, Canadians need preventative care given at the point of their home by local nurses who understand what's available and the resources that are available. That's all I have for today. Thank you very much.